Case 6. Let's start with Case 6. We have an anteroposterior and lateral radiograph of the left knee in a skeletally immature patient, likely a very young child. There's a well-defined ovoid lucency in the medial distal metaphysis of the left femur. This lesion has a narrow zone of transition, suggesting a benign process. The medial cortex is absent, and there's a small extra-osseous component. The lesion appears mostly lucent, with some sclerosis at the inferior margin. Importantly, there's no periosteal reaction or soft tissue mass. The rest of the bones, including the joint spaces, appear normal. Given the patient's age and the radiographic appearance, my primary consideration would be an eosinophilic granuloma, a form of Langerhans cell histiocytosis. However, the presence of cortical destruction and the extra-osseous component raises concerns about a low-grade malignancy like osteosarcoma. In terms of further management, I would recommend an MRI for better soft tissue characterization and to assess the extent of the lesion, followed by a referral to a pediatric orthopedic specialist for potential biopsy and treatment planning. To summarize, this case presents a benign-appearing lesion with some features concerning for malignancy, possibly an eosinophilic granuloma or osteosarcoma. Case 7. Now, moving on to Case 7. This is an abdominal radiograph of an adult patient. The most striking finding is the massive dilatation of a gas-filled loop of large bowel, which has a coffee bean shape, indicating a sigmoid volvulus. The dilated loop extends superiorly from the pelvis, and there is no evidence of free intraperitoneal gas, suggesting no perforation. Additionally, feces are visible in the cecum, and there are non-dilated loops of small bowel centrally. Osteoarthritic changes in the hips and lumbar scoliosis are also noted. The main concern here is large bowel obstruction, specifically sigmoid volvulus, which can lead to bowel ischemia if not promptly managed. The next step would be an erect chest radiograph to check for free air under the diaphragm, indicating perforation. Urgent surgical consultation is warranted for decompression, potentially via endoscopy or surgery. In summary, the findings suggest a large bowel obstruction due to sigmoid volvulus, requiring urgent intervention. Case 8. Let's look at Case 8. The radiograph shows a Y view of the right shoulder in a skeletally mature patient. There is a posterior glenohumeral dislocation, and I suspect a fracture of the humeral head, although the exact details are unclear. Additionally, there's a large, rounded soft tissue mass in the right lung, visible on the radiograph. This mass is concerning for a primary lung tumor or a metastatic lesion, given its size and appearance. The patient's history will be crucial here. If there's a known primary malignancy, this mass could represent metastasis. For further evaluation, I would recommend a CT scan of the chest to better characterize the lung mass and assess for additional lesions. A referral to a respiratory or oncologic specialist is also necessary for management, including possible biopsy of the lung mass. To sum up, the key findings include a posterior shoulder dislocation and a large pulmonary mass, likely indicating a metastatic disease process. Case 9. Next, Case 9 involves T1 and T2 MRI images of the lumbar spine. There's normal alignment and no abnormality in the distal cord or cauda equina. However, there are small focal abnormalities at the anterior superior corners of the vertebral bodies, particularly at L1 and T11, T12, where marrow signal changes suggest shiny corners. These findings are indicative of early inflammatory changes, commonly seen in conditions like ankylosing spondylitis. The sacroiliac joints are also involved, with florid symmetrical changes and erosions, supporting a diagnosis of ankylosing spondylitis or an arthropathy associated with inflammatory bowel disease. For definitive diagnosis and management, a referral to a rheumatologist is appropriate. Further imaging, including whole spine MRI, may be necessary to assess the full extent of the disease. In conclusion, the imaging findings are highly suggestive of ankylosing spondylitis, characterized by both vertebral and sacroiliac joint involvement. Case 10. Finally, Case 10 presents a portable anteroposterior chest radiograph of an adult patient. The image shows widespread bilateral airspace opacification with a normal-sized heart and no pleural effusion, consistent with pulmonary edema or ARDS. The presence of an endotracheal tube, central venous catheter, and nasogastric tube indicates a critically ill patient, possibly with respiratory distress syndrome or fat embolism syndrome, especially if there's a history of trauma or surgery. The patient requires intensive care management with close monitoring and supportive care, including mechanical ventilation if indicated. The differential is broad, but the clinical context will guide further investigations and treatment. In summary, the chest radiograph findings are consistent with bilateral pulmonary edema, or ARDS, requiring immediate critical care intervention. These cases highlight the importance of thorough imaging analysis, clinical correlation, and appropriate referral for further management. For more detailed radiology case discussions, subscribe to our Radiology Made Easy channel on YouTube. Remember to turn on notifications so you don't miss any updates. Best of luck in your studies and exams.